Thank you, and thank you for the opportunity to come and speak about this topic, which I know is very close to the hearts of many people in this room. I'm going to talk about a few things today. I'm going to give you a quick timeline about some of the antimicrobial shortages, talk about the current process for managing them, then also look at how big the problem currently is, what we know the consequences of shortages to be, what is the role of AMS teams, and then finally a little bit of promising news at the end about what's being done on the shortage front. Now, these are just some of the newspaper reports that I'm sure we've all seen in newspapers. And I know myself, if I was a patient in the community, I'd be very concerned looking at these. And I think this is an important picture to show. Some people in the room may remember the Great Pen shortage of 2011, and I must admit, I thought that was quite exhausting. However, things have gotten a lot more exhausting in the last couple of years, and this is not all the drugs, these are just the ones a few colleagues and I could remember, and it really does show you that the last few years have been an interesting time with regards to shortages. And there is actually a medicine shortage definition, and that in Australia is that a medicine shortage occurs when the supply of a medicine is not likely to meet the normal or projected consumer demand for the medicine within Australia for a period of time. Now, the World Health Organisation have done some work around shortages, and there's actually 26 definitions that exist around the world. It will be very interesting to compare and contrast them all. They have put out a document that does. And there is actually a current process for managing shortages, and it's through the Therapeutic Goods Administration, and it's the Medicine Shortage Information Initiative. And I have to preface this at the moment that this is a voluntary involvement from the sponsors. And the process relies on the sponsors voluntarily notifying the TGA if there's a medicine shortage that's anticipated or is known. The TGA and the sponsors then collaborate, and they use the risk matrix you can see on the screen to determine the impact of that shortage, and then they agree on the responses to that shortage. They then publish standardised information on the Medicine Shortage Information website, which is part of the TGA website, and then the sponsors provide updated status information to the TGA. And I should reinforce again that this is a voluntary process. So just how big is the problem? So the Society of Hospital Pharmacists of Australia did a point prevalence survey in April this year, and they surveyed 280 health service facilities, and 95% of those health service facilities reported at least one medicine shortage on that day. 365 commercial products were not available, and only 15% of those drugs were listed on the TGA website on the Medicine Shortage Initiative section. 70% of respondents found out that that drugs were short when they were trying to order the stock when they needed it. And not surprisingly to most people in this room, the most common therapeutic group of drugs that were short were antimicrobials. And at that point in the year, vancomycin, metronidazole and norfloxacin were the key shortages. And really interestingly, and I think we forget about this sometimes, they also asked the procurement staff, who were the most likely people to be answering this, what action they took in response to the shortage. A lot of the time they accessed emergency stock, sometimes they accessed SAS stock, but there's a lot of work that goes on behind the scenes that I don't know about as an AMS pharmacist that my procurement team do before they come to me and say, Kelly, we've actually got a big problem. There's acquiring different brands, there's getting different dose forms and strengths. A lot of the time there is no alternative, and there's a lot of work that goes on behind the scenes, and I think we all feel from an AMS perspective, this has been a lot of work for us. Spare a thought for the amazing procurement teams who do so much more work behind the scenes before we even find out about it. And so we know there's consequences that come with antimicrobial shortages, and the biggest one that we're all petrified of is an inability to treat infection if we run out of antimicrobials. There's various publications out that report changes in antimicrobial utilisation as a result of shortages, and I'm sure every person in this room can look at their own antimicrobial NORS data and identify trends that are as a result of a shortage. And some of the scary ones are a piptazo shortage and a 111% increase in meropenem use. Others have seen increase again in kefapine shortage, an increase in piptazo and meropenem. Some sites have reported increase in Clostridium difficile rates through a change in antimicrobial use, and others have reported changes in microbiology epidemiology. And so one paper from the US reported an increase in VRE during a piptazo shortage. All those consequences tend to take time to see, and the one that tends to come to attention first is often the expenditure. Now, what Yves Lorenzo, one of my colleagues, and I have done is we've worked out what the usual cost for a defined daily dose of some of the short antimicrobials is. We've then used some of the SAS quotes we have received as a result of investigations for the shortages at that time. We've also then gone back and looked at the NORST data for a 12-month period, which is a national antimicrobial data which tells us just how many defined daily doses Australia uses of each of these. And then we've worked out the additional cost that hospitals would be required to pay if we purely used SAS drugs as a sole way of dealing with the shortage. And as you can see, if we used acyclovir, Australia would need to spend $4 million a year extra on acyclovir. The incredibly scary one is Pip-Tazo. Given the amount we use, that would be $50 million extra it would cost to obtain Pip-Tazo. Now, I do have to say that not all these costs are borne by hospital. There are different processes in place, but this is really worst case scenario. And as I mentioned to you in the procurement slide and how they respond to shortages, decisions about needing to order SAS products often have to happen within a couple of hours because they're finding out when they're trying to order more stock and they have to look and say, it's going to take 7 to 10 days for the SAS stock to arrive. Do we physically have 7 to 10 days worth of stock to get through this period? And sometimes these decisions have to be made very quickly and these costs have to be borne by the hospitals. And so just using 2 Melbourne hospitals as an example, one is Hospital 1 and IV acyclovir. In a 6-month period in 2007, their acyclovir IV expenditure went up by $90,000 compared to the same 6-month period the year before. And that was in response to that shortage and having to acquire SAS stock. The second Melbourne hospital, when vancomycin became short, considered substituting ticaplanin into its place. They did some expenditure projections for 1 quarter, and that was by switching to ticaplanin, it was going to cost that hospital about $75,000 more for 1 quarter to use ticaplanin instead of vancomycin. And a decision was made to make big changes to their vancomycin utilisation and restrict, and they were able to get through that shortage period without switching over. So there are all the really obvious consequences that we think about, but there are a few more, as I call them, discrete consequences. And as many people in this room would know as practicing in AMS, AMS is around culture change. It's around slowly talking to doctors and changing their prescribing habits and trying to encourage them to use narrow-spectrum antibiotics or talking them down from the meropenem ledge down to Pip-Tazo. However, when you have a shortage, suddenly a lot of that hard work can be undone. And suddenly all those messages you've been saying to them for the last 3 years and you've finally built up their trust, suddenly you have to actually just ignore all that for a few months while we have a shortage. So it can actually cause some AMS programs to backtrack a little bit in the amount of work they've done. There's also a lack of prescriber familiarity with some of the substitute agents. And I keep picking on Pip-Tazo a little bit, but if you think about an alternative for Pip-Tazo is ampicillin, metronidazole, gentamicin, I'm not sure how many junior doctors in Victoria would be very comfortable prescribing gentamicin, given we've seen a massive reduction in its use over the last few years. And so we'd have to actually really think about that from a safety perspective for patients. With my pharmacy hat on, we also need to think about the medication safety component of this. We often get SAS products. The product information that comes with it is often not in English, and so we have to acquire that. We often get changes in packaging appearances, and this is 2 of the products we received during the Ben-Pen shortage in 2011. And as you can see, it's written in penicillin G, which is not how we refer to it in Australia, and it's written in millions of units. So you can only imagine what the poor nurse trying to administer 2.4 grams of benzyl penicillin is thinking when she picks this up off the shelf. And so there's a big role for pharmacists to try and ensure that the right information is communicated. And often in the acyclovir example, the change in strength of the vials, we went from 250 milligram vials to 500 and making sure the nurses know about this. The other thing I think we also can't underestimate is the amount of resources that are required to manage these shortages. Every state and territory has a different approach. There are some that have a full state-based approach, whereas in Victoria we very much work within our hospitals, and each of the AMS teams and AMS pharmacists and procurement teams are working on the shortage for their hospital, and health purchasing in Victoria does help with some of the public hospitals. But I can't emphasise enough how much time procurement staff put into this, as well as pharmacists, and it does lead to burnout. And going back to that single-day snapshot that SHPA undertook, antimicrobials only made up 21% of the shortages that day. There's also all the anaesthetic agents that were out of stock, all the cardiovascular drugs. So if you think you're exhausted, how do you think the procurement teams feel with all the other drugs they have to deal with as well? And the other thing as well, we spend so much time with these shortages and educating and doing what we need to do, it means that other AMS requirements don't get done. And so you might be involved in a quality improvement activity, you may have some auditing you want to do, that gets put on the back burner because this one takes priority. So what is the role of AMS teams in antimicrobial shortages? And we've really seen an evolution from the traditional pharmacy involvement in drug shortages through to a full multidisciplinary AMS team response. And Eves has kindly shared with me some of the St Vincent's interventions that they've done. And this is an example of a letter they sent to all of their prescribers around the antimicrobial shortages. There's lots of notification and making sure people know what's happening. And lots of support for prescribers is required. And I must say, being an AMS pharmacist in Victoria, there's been excellent communication and a willingness to share resources to try and avoid recreating the wheel for all these situations. And it's shown a very good collaboration between everybody. And Eves has also shared with me the St Vincent's example of how they managed with the Pip/Tazo shortage earlier this year. They had a very coordinated response when the shortage was first announced for them in about May, and they restricted their Pip/Tazo to high priority areas like haematology and ICU. They removed it from all other ward impress, and all of those uses outside of those specialty units required ID approval. Lots of discussions were held between the AMS team and high volume users around the hospital, and there was around-the-clock support provided to those prescribers. And the results, as you can see from Eves' graphs, really do show that they were able to reduce their Pip/Tazo use significantly, but unlike some of those literature articles, they didn't see the increase in meropenem use. They managed to keep that trucking along at the same amount. What they did see was an increase in promoted alternatives, which were really your broad-spectrum cephalosporins, your cefepime and your ceftazidime. And unlike some of the papers and other options we've seen today, they didn't actually see an increase in total cost of antimicrobials. And the important thing at the end of the day of all of this is that the high priority areas like ICU and haematology, oncology, didn't go without their Pip/Tazo and patients weren't affected. And I think most people would have to agree the biggest problem we're all facing at the moment is the notification and communication about these drug shortages. And these are just a couple of screenshots from my computer of various methods I've been notified about things in the last 12 months. This is not including the TGA website, but the top one is a formal notification from a drug company about a shortage. The second one is the pharmacist email group that goes around the country with someone sort of saying, oh, I've heard there's a bit of a shortage. Does anyone know anything about this? And that's often how some of us found out about these different shortages. And the bottom one, which I don't think has projected particularly well, was the gentamicin recall a few weeks ago, which was a forwarded email from our infection control lead at 6:03 on a Friday night. And they'd heard about the recall on their infection control email list. And so I said, had you heard about this this recall? Let's just say my Friday night didn't go quite according to plan, as my entire hospital's gentamicin stock was affected. And so the biggest issue we have with these shortages is we don't have the information we need to make the decisions we need to make. We're getting lots of different mixed messages, particularly with different state management of things, lots of mixed messages to the people who need to know, and that results in mixed messages going to the frontline staff as well. And in Victoria, a lot of doctors work across different hospitals. The restrictions in one hospital may differ to the restrictions in other hospitals, and so there is very mixed messages going to everybody. And we know that this is multifactorial. It's not wholly responsible to the drug companies. It's partly drug companies. Some of it's the way our buying groups work. Some of it is bigger than that. So what we really need is increased transparency, and we really do need a coordinated response. We have started to see more of a coordinated response with some of the latest shortages, and the Australasian Society of Infectious Diseases put out their notification of the shortage, which was endorsed by the Society of Hospital Pharmacists, and provided advice for clinicians about alternative agents. In addition, NCAS have been producing their shortage notifications and providing alternative options for people. And this has really meant that we haven't had to recreate the wheel at all the different sites, and so we are starting to see this coming through. But what is really interesting is that there is a bit of movement happening at a national level. And there is interest from the National Health Minister, and he's actually convened some high-level working party meetings. There's representatives from key professional societies around the country, including medical and pharmaceutical, and they've already had a few meetings held in late October and November already. They're currently working on options paper about how the shortages should be managed, and unfortunately I'm not allowed to say much more than that. But we'll include things about how shortages are defined, and also working through the consultation, engagement and coordination of response and reporting, and what are the options there. So I think the important thing at this point in time is to watch this space, because there are people who are working on this at a much higher level than us. And then just to finish up today, we know that medication shortages have become increasingly more frequent, and antimicrobials do make up a large proportion of these shortages. There's a lot of consequences associated with the shortages, and we have to think about the ones to the organisms as well as behind the scenes to the poor procurement staff. We do need a centralised and coordinated process to reduce the impact, frequency and severity of these shortages, and hospital AMS programs really can be an effective local response to these shortages. And I really do have to acknowledge Eve Lorenzo from St Vincent's Hospital and my director, Professor Michael Dooley, who's also the president of the Society of Hospital Pharmacists. Thank you.